So, Don, as you know, many NHS commissioners are considering changes to how we pay for services. There's a broad sense of dissatisfaction with our current systems, in particular fee-for-service, and commissioners are considering quite a range of alternative options, including capitation, returning to block grants, and so on. What's your sense of what's gone wrong with our current payment systems in the UK and in the US? And what's your advice to commissioners on what we could do differently? How do we go about reform?
A lot's gone wrong. I know more about the US. Complexity is an enemy. We've set up these complicated calculations about how to pay. It really distracts the workforce and forces games into the system. It's bad. Reductionism. We want health and well-being, and we attach payment to what we can measure, when the variation in the measures and the real meaning is wrong. The psychology is off base. Most of the workforce, if we talk about individual payment, want to do well, and we treat them like with carrots and sticks. It produces immense misunderstanding. It's way off base. I'd say avoid complexity at all costs, because it isn't going to help us.
Mm-hmm. So, do we just hand the money over to providers?
Here's how I think about it. I think we need to get out of paying people so that we provide incentives to do the right thing. That's stupid. It doesn't work. It's so well embedded in the traditions of payment and management that it's very hard to criticize it. But I will tell you, it is wrong. We need to think about payment as a support system. It's pay to support the activities we wish to emerge. At the individual level, to me, that pretty well comes down, I think, to salaries. To just pay people to come to work, and then use management and supervision and psychology to help them do a better job. And if they're screwing up, fire them. But don't assume you can adjust these metrics so that people do the right thing. You will demoralize them. At the organizational level, I favor aggregate budgets, where we turn over to organizations who will accept responsibility for populations, an allocation that allows them to take care of the population. We watch closely, because we don't want skimping, we don't want nonsense, we want high quality. All of that has to be watched. But I think that the idea of a pool of funds which become a common resource for care of a population is sort of the right way to think. That's the structure of payment that's likely to work best.
Now, of course, we used to have block grants in the NHS before we introduced payment for activity, and there was a lot of concern about those arrangements. There was concern that there was insufficient motivation for providers to offer access to services and insufficient motivation to improve the quality of individual services.
I view that as a management issue, not an incentive issue. It's the job of leaders to direct people's attention in the workforce to what's really important and to help them get that job done. There will, in any workforce, be three populations. There'll be people who are just not doing the job. That's a hard management job. They may need to leave. And there's a small number, but get about the job. Get about that, because there are problems there. There'll be heroes, thank goodness, people who will be creating a new future. They're not responding to incentives. They're intrinsically motivated. The rest of the people in the workforce, they're like most people. They come to work every day. They do their best. They try. Not as hard as you wish, but not as little as you might think. And they need to learn and be supported and encouraged to do better. And that is leadership beginning to end. And when you take incentives as the primary way to work with that good-hearted middle, you create consequences that aren't favorable. Competition, jealousy, hiding, dissimulation, niggling arguments. Who has time for that? Improvement, learning is the job.
So, commissioners in the NHS have been operating with a purchaser-provider split, with arm's-length transacting relationships with providers since the 1990s. And as you say, the sense that we need to use financial levers and incentives to drive performance within commissioning is really deeply rooted. If commissioners aren't going to spend their time and energy devising financial schemes, what else should they be spending their time and money on?
Well, first, the purchaser-provider split should be reconsidered. We need purchaser-provider partnership. Both of you jointly serve the communities in which you are stewards. You have to do that together, and collegiality works. Can I tell you a story? I become bemused by the work at Morecambe Bay on healthy children. Dr. Andy Knox, his GP, got the idea. He thought he could help improve the well-being of the kids by bringing in the daily mile, a mile-a-day run. He went to his CCG, the commissioner, and said, you know, if you give me 2 days a week, just treat them, I think I can get health into our schools. And they said yes. We want to call that incentive? Yeah, of course there was payment involved, but no, this is the release of energy, and that's the kind of partnering I think we need.
So I guess you're saying, Don, the best thing we can do with our financing systems is get rid of the obstacles we've created.
The obstacles of complexity, competition, demoralization, scrutiny, as if it were the tool. It's a vast misunderstanding. I will admit, you get 10 experts on payment into the room with you, 9 will disagree with me. I just don't think they're right, and I've seen the evidence.
Don, thank you very much.
Thank you.